Universal health coverage for South Africans is edging ever closer. The National Health Insurance Bill has been introduced to Parliament and aims to provide health care to all South Africans and designated foreigners. But exactly how will this ambitious project be rolled out? And crucially, how much will it cost the taxpayer? Well, Health Minister Dr. Zweli Mkhize joins me now to discuss all these pressing questions. Good evening, Kawazela. Thanks very much for your time. It's going to cost around, what, about 256 billion to implement just the first 3 years of this program. Does that take into account the figure, that is, the rather precarious economic situation that the country finds itself in?
Well, the figure that you are quoting was based on an estimation that was done in a projection in 2010. At that time, Treasury felt that it would be affordable except for a minor shortfall. Right now, what we have is, I can just group the figures into maybe 2 or 3 figures. Firstly, between now and the next, and the MTF, this is the next 3 years, we'll start at about 75 million rand to set up the unit, and then by the third year, which will be costing about 485 just to run the administration. But the figures that have been allocated are the figures of what's already in the budget, so we're simply just shifting the money inside the unit. Then by 2025, the estimation is that we'll need an additional 30 billion rand, and that is what Treasury has estimated. Then going further, Treasury is working on a paper that's going to give us much more close-up projections of what the cost will be. But generally, the fund will be the NHI will be funded from the general taxation, the general collections that would have come from maybe from employer, employee, and so on. But that will come out of a money bill that Treasury will be able to produce at the time. Now,
were there no red flags raised at the last cabinet briefing, for example, with everybody there knowing that you were now going to come out of there and go and table this bill before Parliament? Did the Minister of Finance, for example, not say, hang on, guys, there's a few issues that we may have to revise given the current state of the South African economy?
Well, the Minister of Finance has got a team that is working continuously on the matter, and so that paper will be published in the next matter of a few weeks to give us what's the latest estimation on that. But let me put it this way. The issue of the national health insurance is about saying there's some money, for example, the government puts onto the medical aid, what we call medical aid tax credits, that is all public sector money that should in fact, be also put in the pool. And so out of all of this, we want to be able to create a social solidarity where the more wealthier subsidize the poorer, where the younger subsidize the older, the sicker are subsidized by the ones who are healthy. And that's the kind of balance. Now, this gives you a bit more of an equitable distribution of the health services. That's what happens in many of the advanced countries. They invest in health and then equitably distribute the funds so that it actually helps as a part of creation of economic growth, investing in a healthier population.
But then apart from the general tax revenue and the shifting of funds that you're talking about, but also apart from the reallocation of the funding of medical schemes, which we have just spoken about, there will also be further taxes, won't there?
Well, that is something that we'll have to deal with. All we're saying is that the Treasury will then assess what additional allocations are needed, what additional taxation, if there's any. But every year the Treasury comes with a money bill. And so before they come up, for us to make a lot of predictions, it's actually difficult. All we can say is that there's a broad envelope of where they could be looking for money. And that for us is acceptable because it's within the ambit of what they have to do.
But when will we know that Treasury is looking at this and the other possibility in perhaps more precise terms with regard to the taxation?
At the moment, we've put the provisions of where the possible sources could be. But only when the time arises, which will be okay, let me also put it this way. This NHI, a lot of what we're going to be doing, we're going to be funding from the existing resources. And as the implementation continues, and then the more closer calculations are done, then we'll actually have a money bill. That's the point at which we can talk about if there is what is new, what is additional, and so on. Certainly, we believe that the combination of what is being spent in the public sector and the private sector, if it's well distributed, it will actually increase a pool from which all the services will be funded. So we certainly believe that it will be a bit more than what the public sector alone is spending, but it will be much more equitably distributed at that point.
Now, there are people who believe that you have jumped the gun here because if you look at the pilot projects, the report of the pilot projects which came out recently, it didn't give you any information you could learn from about whether, in fact, we are ready to implement this.
Well, there are two types of people you're going to find in the country. Those who are dead against NHI for their own reasons and those who are for the NHI for obvious reasons. Now, between these two, we need to tease out what is factual, what is not. In terms of the pilot projects that were done, there's a lot of learnings that has come from there. It doesn't say you can't do NHI. It just basically says there are weaknesses here, there are successes here, there's strength here.
Yeah, or there are areas where they couldn't express an opinion.
Well, look,
so aren't those things, the things we're supposed to take to implementation?
No, that's not how it should work. Here you've got challenges in the health sector, public health sector, staffing issues, supply of medicine, quality issues, management issues, infrastructure issues, organization of the health services, financing issues. All of those issues are on the table. We want to sort all of those issues out, and then we use the guideline of what we need for NHI to guide us how far we need to revamp all of these services. Now, if you want to start NHI, you don't need to get the country to be in a better economic situation than it is now. Most of the countries, when they started NHI, they introduced it when they were even in a much worse situation than South Africa is, and therefore it's not a reason, the challenges are not a reason why not to start NHI. There are some of the issues that people are raised are quite real, some of the points that I'm raising, including, for example, the issues of concern about corruption. Those issues are real, we have to actually deal with, because you can't say you cannot run a government because we've seen corruption. We must just be firmer on it, we must just make sure that we detect it early and we prevent it early. So the reality in terms of how we deal with this is that NHI is it's something that cannot be postponed, but we need to then take into account how do we solve all the issues that people are raising. And I think they're quite right to raise those issues because they've got to solve them. Either way, they are not good for a current health service, they're not good for NHI.
Well, speaking of accountability, I mean, yes, you're going to have a board, you're going to have an advisory panel, it's going to be fund is going to be run by a CEO, but I guess, I mean, given the problems we're sitting with right now, among them, ESCOM, how are you going to ensure that, the fund doesn't become another ESCOM?
Well, there's a slight difference between two. Under the Public Finance Management Act, there are two types of entities. There's Schedule 2, which is ESCOM, Alexco, and some of the big ones. Then they've got also Schedule 3. Schedule 3 are allowed to run the fund, but they get their funds from the fiscus. They get, it's appropriated from the fiscus. They can't go and decide that they're going to, cut out some money and go and take risks and then say we lost it in an investment and so on. They are only allowed to manage it in the way that it has been designated because it comes from the fiscus. So we believe that all we need is to have a much stricter management over those. But I think there's no way we run away from the fact that we're all concerned about corruption, and South Africans have to be vocal about it. We have to be very firm about it, and we have to actually fight against corruption. And there can't be a way we can run a system if we don't do much to fight and uproot corruption.
Now, I think most people accept that our healthcare system has been operating inefficiently. It's not sustainable at all, where a majority of South Africans have to rely on these overcrowded and unfunded.
By the way, both are unsustainable, both public and private.
Yes, but which brings me to what was going to be my question, that there's still an argument out there that the NHI will kill the private health sector on the one hand, but secondly, that it will do a lot of damage to the health professions?
Well, I don't know where they get that from. If you go around the world to look at countries that have got NHI, that hasn't happened in UK, it hasn't happened in Germany, it hasn't happened in France, it hasn't happened in Canada, it hasn't happened, and we're learning from all of those. Now, to think that there's a system that works well in other countries when the same principles are applied in South Africa, then it becomes destructive. I think it's a bit disingenuous. South Africans would be a bit nervous simply because we're trying something new. And those who are nervous about it, I think we must be fair and say we need to show them that, in fact, the system works. I think also this skepticism only helps us to be always alert to say we mustn't allow things to go wrong, because already people are fearful that things will go wrong. But not because there's something wrong with the principle of universal health care coverage. Literally all the top countries in the G20, the richest countries, are actually moving everyone and are saying to South Africa, you are remaining behind. WHO has said the same. And so it's an issue that we must argue about how do we prevent wrong things from happening. And when South Africans are raising that, I think they are right.
Now, a question that a lot of people who are asking is, what, in your view, just in a summary form, will, for example, NHI cover, and what becomes then the role of the private healthcare sector, medical aids and so on? Can you just, in very plain and simple terms, say, make examples even of how the two will be differentiated?
Okay, when you say private health sector, it's a very broad thing. Okay, but let's just deal with a few things. We've got general practitioners who are in private. In many countries, NHI has actually incorporated them so that they are actually working within the NHI system. So we'll incorporate some of them into the system. And then when it comes to hospitals, most of the infrastructure we'll use will be public sector hospitals, which will be accredited and upgraded to the right quality level. But in addition, where there might be situations where it is impossible to get public health sector to cover certain things, of course, that will be considered for private hospitals, but it will be in the instances where public sector doesn't have. Then the issue of medical aid. Medical aid's role has been evolving over the years. What was medical aid 25, 30 years ago is not exactly what's happening now. Now, medical aid has to relook at the role that they'll be playing. They'll relook at the packages that they offer, and that will have to be, in addition to what the NHI is covering. NHI will cover literally every South African, and then the medical aids will be able to top up thereafter in terms of what else people would want, which may not be available from the NHI. But we're going to have time during which we're going to be slowly, phase by phase, increasing the packages that are available on the NHI. And then at a certain point, once that is done, of course, then there'll be a whole determination of where we are.
We've run out of time, Kauza, but the Department of Home Affairs is going to play a very critical role here with regard to, for example, access by non-South Africans. Sure. Now, and this is a department often associated with inefficiencies when you listen to people talking about processing visas for tourists, for example, or porous borders that allow people who end up being here permanently, although even though they are undocumented. What have been the conversations with that department?
Interesting. We just had a meeting 2 days ago with the minister in the two departments, and what we're looking at is that the database of Home Affairs should be the basis of a database of beneficiaries of South Africans for NHI. It's the same South Africans, it's the same foreigners who are registered there, so it becomes a system that the two departments are going to work together so that if you go into an NHI institution anywhere, it will recognize you as a South African or a foreigner who's got a permission or a permit to be in South Africa. So that's the role that we're playing. We're going to then work together. So where there are areas of fraud and so on, those will be fewer cases, because we're talking here about close to 60 million South Africans. So we will actually be working very closely. Then we have also agreed that in the next 3 years, we want to make sure that most 88% of children born in hospital must get out with an ID. Then we must then start working on getting towards 100%, so not ID, but a birth certificate with an ID number, so that they're immediately registered into the system. So we will be working together continuously with Home Affairs.
Dr. Mkhize, thank you very much for your time this evening. The Minister of Health, Dr. Zweli Mkhize.